hyperpigmentary disorders. Under this heading, we'll be discussing various hypo and hyperpigmentary disorders. So let us first discuss hyperpigmentary disorders. Hyperpigmentary disorders. See, most of the hyperpigmentary disorders are due to excessive melanin. Excessive melanin, and this excessive melanin might be present in epidermis or it might be present in dermis. Now, how you are going to differentiate that whether this melanin is present in epidermis or dermis? Simply look at the color of the lesion. And second, you can also do Wood's lamp examination. Just now I will tell you what is Wood's lamp, but for now just remember that you can differentiate with the help of Wood's lamp also. Now, how you can differentiate? See, when the melanin, excessive melanin is present in epidermis, the lesions appear brown or black in color. While when it is present in dermis, it appears blue in color. Under Wood's lamp light, this epidermal melanin accentuates. It appears more dark, while there is no accentuation, no darkening under Wood's lamp light if the melanin is excessively present in dermis. Now, we all know that melanin is brown or black in color. So the lesions also appear brown and black in color. But why the same melanin which is brown or black in color when present in dermis appears blue? Why this blue color is seen? The reason is that this blue color is due to Tyndall, also known as optical effect. So this is due to Tyndall or optical effect. Okay, now what is Tyndall or optical effect? This is partial scattering of different wavelengths of light. Okay, so when the light scatters, what happens? It scatters at different angles. So different wavelengths of light is scattered at different angles. The most of the light which is reflected back is blue in color, and that's why these lesions, they appear blue in color. Okay, so this is known as Tyndall effect, that is partial scattering of different wavelengths of light. Okay, so that's why when the melanin is present deep in the dermis, the lesions might appear blue in color. Okay, so first pigmentary disorder here is melasma. So first one is melasma. If we talk about the etiology of this condition, it can be hormonal, like after OCP intake, after hormone replacement therapy, after pregnancy. Sometimes it might be associated with endocrine disorders like hypothyroidism. Second is due to excessive sun exposure, especially ultraviolet B radiation exposure. So it can be hormonal or it can be due to excessive sun exposure. Now, how they clinically present? Clinically, there are different types of melasma. One is centrofacial. This is the most common type, and it is very obvious from the name itself. This is centrofacial. So central part of the face is involved. What is the central part of the face? That is nose, cheek, forehead. So if this portion is involved, it is centrofacial type. This is the most common type, where there is involvement of cheek, nose and forehead. And over these sides, what you are going to get, because if you recall, I told you in the beginning also that melasma is due to excessive melanogenesis, and due to excessive melanogenesis, there is excessive melanin and the lesions are brown in color. Okay, so here you will find brownish discoloration. Over which sides? Cheek, nose and forehead. There is another type that is known as mandibular. So obviously here also there will be brownish discoloration, but over lower face, mandibular area. Then third is maxillary. So here outer upper portion is involved. So if the lesions are present over outer upper portion of the face, that is maxillary area, that is maxillary type. Mandibular type if the lower face, and if central part of the face, then centrofacial. Centrofacial is most common, where the lesions are present over cheek, nose and forehead. Now diagnosis is clinical. How you are going to treat this patient? I told you it is due to excessive melanogenesis. So you need to reduce this melanogenesis. And to reduce this melanogenesis, what do you need to give? Melanogenesis. What is the rate limiting enzyme? Tyrosinase. So you need to give what? Tyrosinase inhibitors. So treatment is tyrosinase inhibitors. They are lightening or depigmenting agents. These are the examples of topical tyrosinase inhibitors. First, hydroquinone. Second, azelaic acid. Third, kozic acid. Fourth, arbutin. So hydroquinone, azelaic acid, kozic acid, arbutin, all these are the topical tyrosinase inhibitors. So you can simply, these creams are available, so you can simply ask the patient to apply over the melasma lesion, and because they are tyrosinase inhibitor, gradually this pigmentation subside. Now, as I told you, there is role of sun exposure, that is ultraviolet B radiation. So sun protection is also very important in these cases. Sun protection can be advised in two forms, that is physical sun protection or chemical sun protection. Physical, that is ask the patient to cover the face, use umbrella, and chemical, ask the patient to apply sunscreens. So sunscreens are also very important in the treatment of this condition. Now remember one important fact here. First is Kligman's formula. See, Kligman's formula is used in treatment of melasma, and this scientist Kligman, what he did, he added three things. These three things were hydroquinone, tretinoin, and steroids. This triple combination, that is the combination of hydroquinone, tretinoin, and steroid, is topically applied over these melasma lesion, and this is very effective in the treatment of melasma. So remember that Kligman's formula is used in the treatment of melasma. This is topically applied, and this is combination of three things. This is a triple combination of hydroquinone, tretinoin, and steroids. So this is Kligman's formula. Second important point, exogenous ochronosis. Exogenous ochronosis. Now all of you might have read about ochronosis in alkaptonuria, isn't it? And there the cartilage become dark in color due to deposition, and that is endogenous cause. This is, we are talking about exogenous, outside. So sometimes what happens, there is bluish gray or slate gray discoloration of skin. So bluish gray or slate gray discoloration of skin due to excessive topical application of hydroquinone. So I told you hydroquinone is a tyrosinase inhibitor. It is a lightening agent. It is a depigmenting agent. But sometimes what happens, due to excessive application of hydroquinone, it start depositing in the skin, and it might lead to darkening of the skin. So this is one side effect of hydroquinone, and that is exogenous ochronosis. Because you are applying from outside, this is known as exogenous. Okay, so this is one side effect of hydroquinone. So instead of lightening, it can cause darkening as well. Okay, so you need to cautiously use it. Then third, contact leukoderma. See, leuco means white, derma means skin. So this is lightening of the skin, that is leukoderma, white skin is seen, and this is due to contact to something. Okay, so this is known as contact leukoderma, because recently question was asked, so let us understand this. So what happens, due to contact to a chemical, sometimes the skin where this contact of the chemical occurs, that portion becomes white. So this is known as contact leukoderma. Now this can be due to various chemicals like para, tertiary, butyl phenol. This is present in adhesive. Para tertiary butyl catechol. This is present in hair dye. Mono benzyl ether of hydroquinone, which is present in rubber. So at least remember these three important chemicals: para-tertiary butyl phenol, which is present in adhesive; para-tertiary butyl catechol, which is present in hair dye; and monobenzyl ether of hydroquinone. Hydroquinone, you already know, is a depigmenting agent, and this monobenzyl ether of hydroquinone is a so potent depigmenting agent that wherever this is applied over the skin, that portion of the skin becomes white. So it can lead to contact leukoderma. Okay, now these chemicals are present in these things like adhesive, hair dye, and rubber. So sometimes what happens, patient applies adhesive and at that side the skin becomes white. Patient applies hair dye and over that side where this hair dye come in contact with the skin, that portion becomes white. Or sometimes wherever the rubber comes in contact, that portion becomes white. So this is known as contact leukoderma. These are the things and the chemicals which can lead to it. Okay, so sometimes you might find that a patient comes to you with white lesions only over this side. Okay, so what is the reason? So if white lesions are present only over this side, rest of the body is perfectly normal. What is the cause? Yes, due to rubber sleepers. So wherever rubber sleeper comes in contact with the skin, and rubber contain monobenzyl ether of hydroquinone, so this leads to contact leukoderma. Similarly, if a female patient comes with white lesion over center of forehead, so what females apply over center of forehead? Bindi, and they stick it with adhesive. There is adhesive present behind the bindi, and that adhesive may have what? Para-tertiary butyl phenol. So wherever they apply bindi, that portion may become white. Okay, so that is contact leukoderma due to adhesive, due to bindi. Okay, so this is again an example of contact leukoderma. Similarly, if the patient applies hair dye and over this area, that is the scalp area, if the white lesions are present, then it might be due to catechol. Okay, so remember this. These are examples of contact leukoderma. We are writing important facts. In important facts, next one is UV spectrum. So UV spectrum ranges from 200 to 400 nanometer. Okay. Now this UV radiation is divided further into UV A, B and C. Okay, so you need to remember the wavelengths of A, B and C, and it becomes very simple to remember if you remember in the reverse order, that is UV C, UV B, UV A. Now this UV A is further divided into UV A1 and UV A2. So this also in the reverse order, that is A2 and A1. So remember that 200 to 290 is UVC, 290 to 320 is UVB, 320 to 400 is UVA, 320 to 340 is A2, 340 to 400 is A1. Okay, so this is the range of UV A, B and C. Okay, now the first division is at 290. Why? Because ozone layer cuts here. Okay, so because ozone layer cuts here, wherever the ozone layer is intact, there this wavelength do not pass through. So UVC, that is 200 to 290, do not pass through the ozone layer. So in the atmosphere around the earth, UVC is not present except for those sites where there is hole in the ozone layer. Otherwise 0% of the UVC reaches earth. Okay, UVB is around 5% in the sunlight which reaches earth, and remaining the majority is 95% UVA. Okay, now another important point, UVC is germicidal. This is germicidal. UVB is medically very important because this is the sunburn spectrum. It causes sunburn. Okay, now so sometimes they ask you that which UV radiation is germicidal, which causes sunburn. So remember these 2 points. Okay, now if there is excessive exposure to these, they might lead to certain side effects, like because ozone layer cuts, UVC generally do not reaches earth, but at places where there is hole in the ozone layer like Australian continent, what happens that UVC also reaches earth. Okay, so due to which the side effects occur, and this is one important side effect of UVC radiation, that is, so you can write down side effect, it is cataract. So it can lead to cataract. Similarly, UVB can lead to sunburn, and UVA can lead to photoaging. Photoaging. So one is normal wrinkles which develops due to old age, and one is wrinkles which develop due to excessive sun exposure, and the cause is UVA. Okay, if you forget these side effects, you can very easily recall in the examination hall. C for C. So C causes cataract, B for B causes sunburn, and A for A causes aging. So these are the side effects which you can remember. Now after melasma, second is cerulloderma. Cerulloderma. Do you know what is the meaning of this term cerullo? Cerullo means blue, and derma, all of you know, means skin. So sometimes patients, they present with blue colored lesions or blue skin. This is cerulloderma, and these are the examples of cerulloderma. First is Mongolian spots. So you can write on one point here, Mongolian spots. These are bluish discoloration over lower back, bluish discoloration over lower back in infants. So this bluish discoloration which occurs over lower back in infants is example of Mongolian spots. Second example is nevus of Ota. Nevus of Ota. Here you can write down, it is bluish discoloration along the distribution of ophthalmic and maxillary division of trigeminal nerve. So bluish discoloration along ophthalmic and maxillary division of trigeminal nerve. Second point, usually unilateral. So lesions are unilateral. Third, nevus of Ito. Here you can note down bluish discoloration. So here also lesions are blue. So bluish discoloration along the distribution of acromioclavicular nerve. Lesions are unilateral. Along the distribution of acromioclavicular nerve. Where you have written acromioclavicular nerve, you can write down in bracket mainly posterior supraclavicular. So posterior supraclavicular nerve and lateral brachial cutaneous nerve. Okay. So in nevus of Ota, trigeminal nerve is involved. Trigeminal nerve, mainly ophthalmic and maxillary division. Here acromioclavicular nerve is involved, mainly posterior supraclavicular nerve and lateral brachial cutaneous nerve. In both, the lesions are unilateral. Now this Mongolian spot is a self-limiting condition. So this is a self-limiting condition. Within few months of birth, they resolve. Maximum by 1 year, all of them resolve. So no treatment is required. But these two persist. And that's why the treatment for these two, that is nevus of Ota and Ito, the treatment is ruby laser or anti-yag laser. So laser therapy is done. Why laser therapy? Because I told you that the lesions are blue, and when the lesions are blue, when the melanin is present deep in the dermis. So because the melanin is present deep in the dermis, you need to go deep into the skin and treat it. Okay, so with the help of laser light, we target the melanin which is present deep in the dermis, and that's why laser therapy is required. Now lasers have various mode like continuous mode, intermittent mode. Similarly, there is one mode that is known as Q-switched mode. And this is very effective in these patients. So that's why we use Q-switched ruby or Q-switched ND-YAG laser for the treatment of nevus of Ota and Ito. So these are three important examples of cerulloderma. In all these three conditions, the lesions are blue in color. So here let us see few images. This image is of congenital nevus. Just now we will discuss what is congenital nevus. First, let us see melasma. So I told you in melasma, there is excessive melanogenesis. So there the brownish lesions are seen. So you will find this brownish discoloration of skin in the centrofacial type, mainly over the cheek, nose and forehead. I told you under Woods lamp light, epidermal melanin accentuates while dermal melanin do not accentuate. So this is the Woods lamp. If you have not seen Woods lamp, this is the Woods lamp. Remember, Woods lamp is handheld device. So you can see this is the body of the Woods lamp, this is the hand piece. So this is the handheld device, and there is a glass window through which you examine the lesion, and on either side of the glass window there are fluorescent lamps which are present. Okay, now these fluorescent lamps, they emit light in wavelength 365 nanometer. So they emit light in the wavelength of 365 nanometer. If range is asked, it is 320 to 400 nanometer. Okay. So can you tell me that Woods lamp is which lamp? UVA lamp, UVB lamp, UVC lamp? Yes, it is in the range of 320 to 400, and just now I told you 320 to 400 is which wavelength? Yes, UVA. So this is UVA lamp. So Woods lamp is UVA lamp, but if range is not given specifically, they ask you, then remember that this is 365. Now there is a filter in Woods lamp, and this filter is made up of barium silicate and 9% nickel oxide. So this is also sometimes asked, that filter of Woods lamp is made up of. So remember, it is made up of barium silicate and 9% nickel oxide. Okay, so when you how to examine, you can ask the patient to sit in a dark room, switch off all the lights and then turn on the Woods lamp light, and under Woods lamp light you can examine through this glass window, through this filter, and then you will find this accentuation. A Woods lamp can also be used in diagnosing other conditions which we will be discussing later. This is Mongolian spot. I told you Mongolian spot is an example of ceruloderma where bluish discoloration is seen. So you can see this bluish discoloration. Generally it is seen in neonates and in infants, and where in the lower trunk. Okay, so this is the bluish discoloration. Sometimes other sites might also get involved. Then nevus of Ota. I told you nevus of Ota is generally unilateral. So you can see only one side is being shown, and here the bluish discoloration is present along ophthalmic and maxillary division of the trigeminal nerve. So because ophthalmic and maxillary division is involved, you will find this bluish discoloration over maxillary area and in the eye. So if bluish lesion is present in the eye, in the sclera, then obviously you will mark what? Nevus of Ota. While nevus of Ito occur along the distribution of acromioclavicular nerve. So you know acromioclavicular nerve, this is acromion process, this is clavicle. So commonly this site is involved, that is the shoulder area, neck area. So if shoulder area, and again the lesion is unilateral, so if only one side this bluish discoloration is present over the shoulder girdle, then you should suspect, or clavicular area, supraclavicular area is involved, then you should suspect nevus of Ito. Okay. Now we are going to discuss few more nevus which are seen in dermatology. They are not very important, but sometimes they appear in the options. So you can just remember few points about them. If they are asked, you can mark them correctly. Like one is Becker's nevus. The important points about Becker's nevus which you need to remember are Becker's nevus, brownish discoloration, in bracket you can write down hyperpigmented patch with hypertrichosis. Usually site is upper trunk, seen in adolescence, teenage. Okay. So these are the important points. Sometimes what happens during the teenage, during adolescence, patient presents with this hyperpigmented patch, and in this hyperpigmented patch, this dark patch, you will find growth of lot of hair follicles. So with hypertrichosis. So if you find hyperpigmented patch with hypertrichosis during adolescence, then this is Becker's nevus. Okay, now remember that nevus term means nevus. If only nevus is written, nevus means what? Nevus, if you go for the literal meaning of this term, it means birthmark. So most of the nevus, they are present since birth or in the initial few months of the birth. Okay, but this is one nevus which is a misnomer here, because this do not develops in the initial few years, it develops during adolescence. So remember this point, and this is more common in males. So you can see few more patients over upper trunk. Okay, so upper chest, upper back, shoulders, this is the common sites. You will get this hyperpigmented patch, and in this hyperpigmented patch, gradually you will find lot of hairs start developing and this hypertrichosis develops. Okay, so if this is the presentation, then this is Becker's nevus. Then another is halo nevus or Sutton's nevus. Okay, so this is known as halo nevus or Sutton's nevus. Here there is benign melanocytic nevus surrounded by depigmented margin. So sometimes what happens, you will find this melanocytic nevus. This is a benign mole-like lesion which is normally present, but around this mole, patient start developing this depigmented halo. And because this depigmented halo is present around the lesion, this is known as halo nevus. Okay, this is also known as Sutton's nevus. Okay, and once you excise melanocytic nevus, this depigmentation gradually resolves. Okay, so this is known as halo nevus and the treatment is excision. Then nevus spillus, this is also known as speckled lentiginous nevus. So you can write down one point here: circumscribed hyperpigmented macules in localized area. So localized area or circumscribed, that is within one small area you will find these hyperpigmented macules. So these small macules are present. You can see all of them are separate macular pigmentation and they are circumscribed or grouped together, and they are circumscribed or grouped together in this one small area. So that's why it is known as speckled nevus or nevus spillus. Spillus, it appears as if you have spilled them over one small area or you have speckled them over that area. Okay, so speckled nevus or spillus. Now there are a few very important points about this condition which you need to remember. The first one is, it is X-linked dominant condition. X-linked dominant. There are so many X-linked recessive conditions, but there are very few X-linked dominant conditions. This is one of them. So this is X-linked dominant conditions. Like you might have read about other dominant conditions, X-linked dominant, like Rett syndrome, vitamin D resistant rickets, Alport syndrome. Similarly, incontinentia pigmenti, this is X-linked dominant. Involves eye, teeth, CNS and skin. So lesions are not just present in skin, there might be involvement of eye, teeth and CNS. Okay. Now if we talk about skin, over skin, there are 4 stages which are seen. There are 4 stages. So there are 4 stages of incontinentia pigmenti. You just need to remember one word in each stage. Okay, the stage 1 is inflammatory. So here lesions are inflammatory, like inflammatory papules, inflammatory vesicles. So inflammatory lesions are present. Okay, so one word is inflammatory. So stage 1 is inflammatory, inflammatory papules, inflammatory vesicles, fluid-filled lesions might also be present. Stage 2, verrucous. Verrucous means rough surface, hyperkeratotic lesions. Stage 3, hyperpigmented. Stage 4, hypopigmented. So these are the 4 stages of incontinentia pigmenti. That is, initially when the child is born, you will find inflammatory lesions. These inflammatory papules or vesicles start developing. Like you can see in this child, these inflammatory lesions are present. They are red in color and they might be papular or vesicular lesions. Okay. Now gradually with time they become verrucous, they become hyperkeratotic, rough surfaced. If you palpate them, they will be rough and hard. They become, with age, they become verrucous. Now once the verrucous lesions heal, they leave behind hyperpigmentation, and gradually with age, as the time passes, it becomes hypopigmented. Okay, so these are the changes which occur as the disease progresses. Okay, so remember this, because in one of the exams this question was asked that which of the following stage of incontinentia pigmenti present with hypopigmented lesions. Options were 1, 2, 3, 4, and then the students got confused that whether hyper occurs first or hypo occurs first, so whether it is 3 or whether it is 4. So remember this, that the 4th stage is hypopigmentary. If you forget this in examination, simply write hypo. So hypo have how many alphabets? 4. So this is the 4th stage. Okay, never write hyper. Why? because hyper have 5 alphabets and there is no 5th stage. Hyper is 3rd. Okay, so remember, hyper is 3rd, hyper occurs first, and then occurs hypo. Hypo have 4 alphabets, so this is the 4th stage. Okay, there are only 4 stages. Now, one more important thing which you need to remember here is that if you notice these lesions, they are following a linear pattern, isn't it? So they are along a linear pattern. They are following some lines. These are which lines? So in continentia pigmenti, the lesions follow lines of Blaschko. So they follow lines of Blaschko. What are lines of Blaschko? These are imaginary lines. So these are imaginary lines of development of skin. So these are the imaginary lines of embryonic development of skin. Okay, so when the skin is developing, they follow these lines. Okay, so these are the imaginary lines of embryonic development of skin, and they do not correspond to blood supply, nerve supply, lymphatic drainage, etc. Okay, so they do not correspond to blood supply, nerve supply, or dermatome or lymphatic supply. They are what? They are imaginary lines of embryonic development of skin. Okay, so once this question was also asked that Blaschko lines correspond to, and the options were blood supply, nerve supply, lymphatic drainage, and one of the option was development of skin. So they are embryonic, they are the lines of development of skin. Okay, so you can see these in these in this image, you can see these lines. These are the lines of Blaschko. Okay, there are few more conditions which might follow lines of Blaschko, like, so one you already know, incontinentia pigmenti. Second is ILVIN, inflammatory linear verrucous epidermal nevus. And third, lichen stratus. So in all these conditions, you will find linear lesions or lesions which are following these lines. Okay, like in incontinentia pigmenti, then ILVIN, that is inflammatory linear verrucous epidermal nevus, and in lichen stratus. Now next is Peutz-Jeghers syndrome. Okay, now you might have read about Peutz-Jeghers syndrome in surgery, because this is one autosomal dominant condition which presents with GI polyps, gastrointestinal polyps. These polyps are present in small intestine or large intestine? Yes, small intestine, jejunum. So these are jejunal hamartomas. So because they present with jejunal hamartomas, this is discussed in surgery, but over skin you might find some features, and these are lentigens. I already have discussed lentigens in the beginning. Lentigens are due to increased localized number of melanocytes. So these lentigens develop, and the characteristic site of these lentigens is perioral. So perioral lentigens develop. Okay, so these perioral lentigens are seen, like you can see here, these dark small lesions which are present over lips and sometimes buccal mucosa. So if this presentation is seen, then you should suspect Peutz-Jeghers syndrome, because this is an autosomal dominant condition which might be associated with GI polyps, that is jejunal hamartomas. So here also dark lesions in the form of lentigens might be seen. Then there are few congenital melanocytic nevus. Okay, so congenital melanocytic nevus can be further divided into, so congenital melanocytic nevus can be divided into 3 types. They can be junctional, they can be compound, or they can be intradermal. Junctional, if this is the cross section of skin, this is epidermis and this is dermis, we know that in between is dermo-epidermal junction. So this is congenital, that is present since birth, melanocytic, that is related to melanocytes, And nevus, I told you, birthmark. So this mark is present since birth. This is a congenital condition, and this is due to proliferation of the melanocytes, or the site of the melanocyte is slightly variable than the normal. Okay, so normally the melanocytes, I told you, are present in stratum basale, that is the lowermost layer of epidermis. During the embryonic development, if they are not present in the stratum basale, they are also present or only present in the junction, okay, at one particular area, junction, that is dermoepidermal junction, it might lead to such lesion. Okay, so these are junctional melanocytic nevus. They are due to presence of these melanocytes in the junction, dermoepidermal junction. Then compound, if they are present in the junction as well as in the upper portion of the dermis, we call it compound. And if they are only present in the lower portion of the dermis, then we call it intradermal. So depending on the site of the melanocytes during in the lesion, you can divide it into junctional, compound, or intradermal melanocytic nevus. So this is the congenital condition, and patient might present with this. So remember, junctional nevus is generally flat and it is dark. So you can see this dark lesion because this is due to excessive proliferation of melanocytes, and where it is occurring in the junction, so this is flat. But the compound one is dark and raised. Okay, so this is raised lesion. This is dark and raised lesion, compound lesion. Okay, this is compound. Here, if you do biopsy, you will get melanocytes both in the dermis as well as in the junction. But if they are present only in the dermis, okay, they might sometimes be skin colored also, but generally they are dark, and it is due to presence of the melanocytes in the dermis. So if you do biopsy, you will find that till dermis the involvement is there. Then acanthosis nigricans is also a hyperpigmented condition. Now the points to remember here are acanthosis nigricans cause. It can be benign, it can be malignant. Benign, like obesity. Obesity is considered as the most common cause of acanthosis nigricans. Okay, so benign is most common, and among them the obesity is the most common cause, while sometimes it can be malignant. Malignant causes can be gastric adenocarcinoma. Gastric adenocarcinoma. Presentation. So clinical features. It presents with, like you can see here over the neck of this patient, hyperpigmented, velvety. So the feel is velvety. Okay, so this is hyperpigmented, velvety discoloration over site is over flexus. Commonly occur over flexus. Flexus like axilla, groin, neck folds. So folds are commonly involved, like axilla, groin, neck folds. So over this you will get this velvety hyperpigmented lesions, and commonly this will be seen in the obese individuals. Now because obesity is the most common cause, what is the treatment? So treatment is generally ask the patient to reduce weight. Here also again you can see over neck folds, in the axilla. All these are the cases of acanthosis nigricans. Then there is one condition, that is xeroderma pigmentosa. Do you know why xeroderma pigmentosa occurs? This is autosomal recessive condition, and it occurs due to DNA repair defect. DNA repair defect means there is nucleotide excision repair defect. Okay, so nucleotide excision repair defect or DNA repair defect. See, normally if you go out in the sun and due to UV radiations, if there is damage in the skin, what happens? If there is damage in the DNA, it normally get repaired. But in these patients, it do not get repaired. Then again they go out in the sun, again some damage occur, it do not get repaired. So what happens? There is cumulative damage. Okay, so whenever they go out in the sun due to UV radiation over their exposed areas, like in this patient you can see over the face, what is happening? Patient started developing lesions. The initial lesions are in the form of, so clinical presentation, initially in the form of freckles. So initially patient develops freckles. Okay, so initially affiliates of freckles start developing, that is hyperpigmented macules which start developing. Gradually what happens? Patient might start developing pre-malignant lesions, and then patient might develop malignant lesions in the form of squamous cell carcinoma. So lot of photo damage develops, and this is early in the age. So in old age Many patients develop squamous cell carcinoma, but early in the age, due to this excessive photo damage and due to this DNA repair defect, these patients start developing what? These freckles. So if the patient is young and developing these malignant or pre-malignant changes like squamous cell carcinoma, and there is a background of freckles over exposed areas like dorsum of the hand, over the face, then you should suspect xeroderma pigmentosa. Okay, so this is a patient of xeroderma pigmentosa. Freckles. See, freckles I told you are associated with xeroderma pigmentosa, but remember that they can normally be seen. Okay, so this is not always due to xeroderma pigmentosa. They can normally be seen like in fairer individuals. So this is common in Fitzpatrick skin types 1 and 2. If you recall, I told you in the beginning, Fitzpatrick skin types 1 and 2, which are common in Western countries. So these individuals in Western countries having skin types 1 and 2, very fair skin color, what happens? Excessive photo damage occurs. So due to excessive photo damage, because the melanin is less, and I told you melanin is helpful in protecting the skin. So when the melanin is less, what happens? Or few melanin is present, that is light colored melanin, what happens? That they develop a lot of photo damage, and this photo damage may present in the form of freckles. So these freckles are seen. I already told you freckles are due to increased localized melanogenesis. So wherever this excessive melanogenesis occurs, these dark lesions might start developing. Okay, so freckles can normally be seen in fair individuals, but sometimes they might be associated with xeroderma pigmentosa as well. Then lentigens, this also I told you, lentigens are different from freckles. How? Because here there is increased localized number of melanocytes. So if you do biopsy, you will find here there is increased melanocytes, and there is increased melanogenesis. Then fixed drug eruptions. So sometimes questions are asked on fixed drug eruptions, and here also dark colored lesions might be present. So if you just remember the name of this disorder, you can remember all the points. Why fixed? Why fixed? Because the lesions always occur over same site. Drug, why? Because it is after consumption of drugs like NSAIDs, tetracycline, cotrimoxazole, which commonly comes with the name of Septran. So these are the common culprit which cause them. Now these drugs, they have a drug specific pattern, like NSAIDs generally cause lesions over lips. Tetracycline, cotrimoxazole generally cause lesions over genitals. So these are the common sites, and every time patient takes an NSAID, lesion will develop over lips. So that's why we call it fixed, same site. Eruptions. So what happens whenever patient takes these drugs and the patient is allergic to this drug, patient develops this fixed drug eruption, and this eruption initially is in the form of erythematous lesion or erosion or vesicle, later which heal with hyperpigmentation. So initially patient will develop a vesicle, like you can see this fluid filled lesion which is present here over genitals. Okay, so over genitals or over lips, patient might develop this vesicle or a bulla, and when this rupture, you will find this erythematous erosion. So erythematous area is present, and after a few weeks or months, you will find that this areas, they heal and they leave behind hyperpigmentation. It becomes dark. So if you find dark lesion localized to glands or localized to lips, and there is a history of drug, then you should suspect fixed drug eruptions. Okay, so these are the patients who are suffering from fixed drug eruptions. So remember these 3 points. Whenever question comes on fixed drug eruption, there will be history that patient was suffering from some condition, took drug like NSAID, tetracycline, cotrimoxazole, and developed lesions over lips or genitals depending on the drug specific pattern, and the hyperpigmented lesions were seen or vesicles were seen. So then this is the example of fixed drug eruptions. But a similar question came in AIIMS few years back, and the option was fixed drug eruption, but that was not the answer. Answer was chikungunya fever. What was the question? In the question it was written that patient was suffering from fever, took NSAID and developed hyperpigmented lesion over tip of nose. Okay, and along with fever, arthralgia was also mentioned. Okay, so patient was suffering from fever and arthralgia, which is the common presenting symptoms of chikungunya fever, then took NSAID. Though NSAID was taken, that might be taken for fever and arthralgia, and developed hyperpigmentation over tip of nose. So I told you NSAID generally causes fixed drug eruption over lips. So if lips was mentioned, the answer would have been fixed drug eruption. But here lips was not mentioned, it was tip of nose, okay, and this sign, that is the chikungunya fever which leave behind this hyperpigmentation over tip of nose, this sign is known as chick sign. This is the short for chikungunya. So you can write down one point here, chick sign. So this is a peculiar hyperpigmentation. So what is chick sign? It is peculiar hyperpigmentation over tip of nose seen in patient suffering from chikungunya fever. Seen in patients suffering from chikungunya fever. So remember, if the sites are lips and genitals and there is history of drugs, and there will be always one history that every time patient takes the drug, similar lesions develop over same site, that is fixed, then you should mark fixed drug eruption. But if tip of nose is mentioned and the features of chikungunya fever are mentioned like fever and arthralgia, then you should suspect chick sign, that is tip of nose, peculiar hyperpigmentation over tip of nose seen in chikungunya fever. Next we will be discussing hypopigmentary disorders. Okay, so next we will be discussing hypopigmentary disorders, and among various hypopigmentary disorders, the most important one is vitiligo. So remember that this is an autoimmune condition, and in this autoimmune condition, what happens? Anti-melanocytic antibodies are formed. So the antibodies which are being formed, they are going and destroying the melanocytes. So there is absence of melanocytes. And because there is absence of melanocytes, you will find depigmented lesions. So depigmented lesions are seen. Depigmented lesions or white lesions are seen. Now, depending on the site involved, there can be different types of vitiligo. Okay, so in clinical features, you can write down types. So here you can see this image. There are different types of vitiligo. Like if this depigmented lesion is localized to one small area, okay, like it is localized to only this area, here localized to this area, then we call it focal. Okay, so focal if it is only localized to one small area. Now if it is localized to mucosa, we can call it mucosal. So mucosal is also a focal type where it is localized to mucosa. Then if it is unilateral along a particular nerve segment, so if the lesions are unilateral along a particular nerve segment like this, we call it segmental. So there is a segmental type where the lesions are unilateral along a particular nerve distribution. Then there is a type known as acrofacial type. Acrofacial. Okay, so it is very obvious, acro and facial. So if acral part and face is involved, so acral part like hand and feet. So if you examine, there will be involvement of feet, there might be involvement of hand, and face is also involved. So if only hand, feet and face are involved, we call it acrofacial type. Okay. Then vitiligo vulgaris. Vitiligo vulgaris is the most common type. So this is the most common type. And here the lesions are generally bilaterally symmetrical. So in segmental type, they are unilateral, only on one side, but here they are bilaterally symmetrical, like on both the sides, here also on both the sides, here also on both the sides, here also you can see almost bilaterally symmetrical, bilaterally symmetrical. So this is the most common type where lesions are generally bilaterally symmetrical. And then there is universalis type where there is generalized involvement. Almost more than 90% of the skin is involved, so only few areas are spared, rest whole body is involved. Okay, so this is universalis type. So these are various types of vitiligo. Focal, when it is localized to one small area. Focal can be also labeled as mucosal, where only mucosa is involved. Then segmental, if the lesions are unilateral along a particular nerve segment, we call it segmental. Then acrofacial type, where hand, feet and face are involved, so that is acrofacial type. Then there is vulgaris type, that is the most common type where the lesions are generally bilaterally symmetrical, and if whole body is involved, then it is universalis type. Okay, now remember one point, that this universalis type is usually associated with, various autoimmune or endocrine disorders like diabetes, so diabetes mellitus, Hashimoto thyroiditis, pernicious anemia, alopecia areata. So these are common associations of universalis type. Okay, so universalis type might be associated with Hashimoto thyroiditis, diabetes, pernicious anemia, alopecia areata. Now remember that there is one type which is known as lip tip type. Lip tip type. This is again one variant, that is lip tip type. Here it is very obvious from the name itself, lip and tip is involved. Okay, so if lips along with tip of nipple or tip of penis are involved, then we call it lip tip type. So if the lesions are only localized to lips along with tip of nipple or tip of penis, then we call it lip tip type. Okay, so these are various types of. Next is prognosis. So if we talk about prognosis, if the lesions are persisting for a very long period, that is long standing disease. If the lesions are mainly present over bony prominences, if the lesions have leukotrichia, if you recall in the beginning I told you leukotrichia, sometimes what happens, not only the skin but the hair follicles also become white. So if the pigment of the hair follicle is also gone, that is leukotrichia. Acrofacial type, when the lesions are present over hand, feet and face. And universalis type, all these have poor prognosis. So these types have poor prognosis. Okay, so remember, long standing disease, lesions are present over bony prominences. If the hair follicles have also lost the pigment, acrofacial type, or majority of the skin is involved, all these have poor prognosis. Treatment. Because this is an autoimmune condition, you can give immunosuppressants, like topically you can use steroids. You can use calcineurin inhibitors. Calcineurin inhibitors like tacrolimus, pimecrolimus, there is also role of vitamin D analogues. Then you can use systemic agents like steroids, azathioprine, levamisole. I already told you levamisole is immunomodulator. Then steroids, remember that if you give daily steroid, it might lead to various side effects. So here also we use oral mini pulse. That is, we give only 2 days in a week. Now, one important form of therapy which is used in vitiligo is phototherapy. Now, phototherapy is very important in these cases and we are going to discuss this in detail. Phototherapy. Photo means light, therapy means to treat. So, we treat with the help of light. So, there are various forms of phototherapy. Like one is PUVA. So, in PUVA what we do? We give Sorolene. So, we give Sorolines to the patient and then we expose to UVA light. See, Sorolene tablets are also available and topical Sorolene is also available. So, whatever you give and then expose to UVA radiation, then we call it PUVA. So, this is very obvious. P followed by UVA. So, P Sorolene followed by UVA. This is PUVA. Then another is PUVA Sol. PUVA Sol. So, here again we give Sorolene and then instead of UVA, we give sunlight. So, if you recall, I told you during discussion of UV spectrum that 95% of the UV radiation which is present in the sunlight is UVA and we require UVA. So, if UVA chamber or UVA phototherapy is not available, the cheaper source of UVA is sunlight, isn't it? So, 95% of the UV radiation in the sunlight is UVA. So, you can use sunlight. So, you are using which energy? You are using solar energy. So, that's why it is known as PUVA Sol. The next is NB-UVB. In NB-UVB, we do not give Sorolene, we just expose to light of wavelength 311 nanometer. So what you are doing, you are using a very specific wavelength of light, very narrow wavelength of light. So that's why this is known as NB, that is narrow band UVB phototherapy. Okay, and UVB, if you recall, what is the range for UVB? Yes, 290 to 320, and this falls in UVB, isn't it? And this is a very narrow wavelength of UVB. So this is narrow band UVB phototherapy. So these are three different forms of phototherapy. There is one more form that is known as targeted phototherapy. Targeted phototherapy. In targeted phototherapy, we use laser. Which laser? Excimer laser, which emits light in 308 nanometer. So if you are using excimer laser, you have a laser probe with you. So with the laser probe, you can directly target the lesion without affecting the surrounding skin. So what you are doing, you are targeting the lesion. So this is known as targeted phototherapy. You are using a laser here. Okay, so these are various forms of phototherapy: PUVA, PUVASOL, NB-UVB, and targeted phototherapy. Now in these various forms of phototherapy, we use Sorolane. Okay, so Sorolane, how they work? What is the mechanism of action? So remember, they bind to DNA. So how they work? They bind to DNA. There are different types of Sorolane: natural and synthetic. One of the example of natural Sorolane is 8-methoxy Sorolane, and synthetic Sorolane is trimethoxy Sorolane. So these are two examples of Sorolane: 8-methoxy Sorolane and trimethoxy Sorolane. As I told you, this is natural Sorolane. This is natural. So since this is natural, it might have plant origin. So this is derived from a plant, seeds of a plant known as Amimajus. So seed of this plant, Amimajus, have this 8-methoxy Sorolane. Okay, so 8-methoxy Sorolane is a natural Sorolane, while trimethoxy Sorolane is a synthetic Sorolane. Now, how this phototherapy is given? Like this Sorolane tablet or topical solution is available. So what you can do, you can give tablet of Sorolane to the patient, then ask the patient to wait for 2 hours and then expose to light. Now this light depends that if you don't have UVA chamber, you can show sunlight, and if you have UVA chamber, you can ask the patient to stand in the UVA chamber. If you are giving topically, then you have to wait for 30 minutes. So apply topical Sorolane, wait for 30 minutes and then expose to light. Now this light which you are using, if it is UVA chamber or UVA unit is available, then you can expose to that. Okay, but if it is not available, you need to expose to sunlight, which is a very cheaper alternative. So the sunlight which is most effective is the sunlight in between 11 AM to 1 PM. So this is the light which has to be used, sunlight. Okay, or you can expose in UVA chamber if it is available, and this has to be given every alternate day. So it is very cumbersome for the patient to come every alternate day and show the light in the UVA chamber. So what we do, we give the tablet, patient ask the patient to take tablet and then wait for 2 hours, and in between 11 AM to 1 PM they have to show the light, and this has to be done every alternate day. So if the patient is using sunlight, then it is PUVASOL, and if patient is coming to your hospital and showing the light in the UVA chamber, then it is PUVA. Okay, so this is the phototherapy which we use. Now, if all your medical treatment fails, then you can go ahead with surgical treatment. Now, surgical treatment is indicated only if your medical treatment have failed and if the disease is stable for more than 2 years. Okay, so if the disease is stable and it is not progressing, then only surgical treatment is done. This surgical treatment can be done in the form of partial thickness skin grafting. This has to be very thin, ultra thin. Why ultra thin? Because what we require melanocytes, isn't it? And melanocytes are present in stratum basale, lowermost portion of epidermis. So partial thickness skin graft which is very thin is required, and what we do, we simply let us consider this is the patient, okay, and this is the lesion. So what we do, we take a partial thickness skin graft from thigh, and this graft is, because this is a normal skin, this have melanocytes, and this vitiligo lesion which is present here, which it do not have melanocytes. So you can place this graft over this side, and the skin which is having melanocytes starts synthesizing melanin, and this lesion improves. Okay, but sometimes what happens, that lesion is very big. So there is a very big lesion and the graft is very small. So what you can do, you can do punch grafting. So in punch grafting, we take out the punches and we place these punches over this whole lesion, and gradually the melanin which is present in these punches, they start synthesizing more melanin around them, and gradually this whole area is covered. Okay, so punch grafting can be done. Then you can also do cultured autologous melanocytic transfer or non-cultured autologous melanocytic transfer. See, both are almost same. Both are autologous melanocytic transfer. One is cultured, one is non-cultured. So see what we are doing here. In the same patient, what we have taken this graft. Okay. Now the graft was small and the lesion is very big. So what you can do, you can keep this graft in a trypsin media which digests most of the keratinocytes, and mainly melanocytes are left. You took this melanocyte and you placed this melanocytes in this lesion. Okay, so what you have done? You have done a melanocytic transfer. The graft was from the same patient, so this is autologous, and you have not cultured these melanocytes, you have simply separated them. So this is non-cultured autologous melanocytic transfer. But if you take these melanocytes which you have separated and keep them in a melanocytic culture media so that you can get more number of melanocytes and then transfer it, then it becomes cultured. And because the graft was from the same patient, autologous, and what you have done a melanocytic transfer, not the whole graft. So that's why this is melanocytic transfer. So these are other modalities which can be used, that is cultured and non-cultured autologous melanocytic transfer. Now the last point here is that in patients who are suffering from vitiligo universalis, where more than 90% of the skin is involved, the concern of the patient is not 90% of the skin. The concern of the patient is remaining 10% of the normal skin. Okay, so almost 90% of the skin is white. Now what is the main? So almost 90% of the face is white. Only small patches of normal skin are left behind. So here the patient do not come for the white skin. Here the patient come for these patches of normal skin. So he wants that the uniform skin color should be there and these patches should also go. So here what we do, here we use monobenzyl ether of hydroquinone. And if you recall, I told you what is monobenzyl ether of hydroquinone? Most potent depigmenting agent. Okay, so wherever it comes in contact with the skin, that portion of the skin becomes white. So what you can do, you can take this and apply over the normal skin, and that normal skin also becomes white. So already the 90% of the skin was white. For the remaining 10% you can apply that and patient will get uniform aesthetic look. Okay, so this is also one modality which can be used, but this is only used for universalis patient, where the concern of the patient is the cosmetic improvement, that is the depigmentation of the normal skin. Now another hypopigmented condition is pityriasis alba. Now whenever you will read about pityriasis alba, there is one more differentiating feature or condition comes to your mind, and that is indeterminate leprosy. Why these two are differential diagnosis for each other? The reason is that both have few things in common. That is, both usually present with single lesion, which is hypopigmented. Both are usually present over face, commonly seen in children. So whenever question is asked on pityriasis alba or indeterminate leprosy, the first sentence is same, that is solitary hypopigmented lesion over face in a child. Okay, so we get confused. So how to differentiate? So to differentiate, you should look for other features like scaling. If you look at the lesions, scaling is usually present in alba, it is absent in leprosy. Sensation is intact in alba. It is plus minus, it might be intact or it might be lost in indeterminate leprosy, because this is indeterminate form of leprosy, initial leprosy. So plus minus. Atrophy if there is atrophy over the lesions, it is probably leprosy. So atrophy is absent, it is present. History of atopy. So you know atopic dermatitis, these patients, one of the minor criteria of atopic dermatitis is pityriasis alba. So many a times this patient might have history of atopy or atopic dermatitis, patient might have rhinitis or atopic dermatitis or conjunctivitis, allergic. Okay, so if that is present, that is suggestive of alba. This is usually absent in leprosy. So first 4 points were same, but with the help of last 4 points, you can very easily differentiate these two conditions. Okay, so if there is a scaling, it is alba. If there is sensation which is impaired, it is leprosy. If atrophy is present, then it is leprosy. And if there is history of atopy present, then it is probably alba. So with the help of these points, you can very easily differentiate. So next time if similar question comes and it is written that solitary hypopigmented scaly lesion over face in a child, answer will be alba. Okay, if it is written hypopigmented solitary atrophied lesion over face in a child, then answer becomes leprosy. So these are the clues which you should look for in the exam. Now remember that alba is a self-limiting condition, and because it is a self-limiting condition, no treatment is required. So no treatment is required, while indeterminate leprosy is considered to be a paucibacillary type of leprosy. So because it is paucibacillary type of leprosy, here PBMDT is given. Later in leprosy we will discuss the details, but for now remember here PBMDT is given. Then next is post Kala Azar dermal leishmaniasis. In short, PKDL. Now here again, whenever question is asked on PKDL, sometimes we get confused with another condition, and that is LL type of leprosy, lepromatous type of leprosy. Why? Because in PKDL, hypopigmented lesions are seen over trunk. They can also be seen in leprosy. Then nodular lesions are seen. Nodular lesions are seen over face in PKDL, and they can also be seen in leprosy, isn't it? In LL type of leprosy, there is leonine facies where there is nodular lesions, or sometimes ENL reaction occurs. There are also erythema nodosum leprosum, so nodules might be present. So if nodules are present, it is not characteristic of PKDL. It can also be seen in leprosy. Then sometimes it is written that patient is from endemic area like Bihar. So not only leishmaniasis, leprosy is also endemic in Bihar. So whenever these points you read in the question, you get confused whether this is PKDL, leishmaniasis, or whether this is leprosy. Now, how to differentiate? Okay, so if these points are same, you should look for these points, that is past history of fever. It is present in PKDL, absent in leprosy. Okay, so past history of fever. Why? Because this is post Kala Azar. When Kala Azar occurred, when visceral leishmaniasis occurred, there was a long history of fever. Okay, now this is post Kala Azar, so there is a past history of fever associated. Other things is you can look for nerve thickening. So nerve thickening is absent here, but it might be present here. Similarly, you can check for sensation. Sensation is intact here, while it might be impaired here. So with the help of these points, you can very easily differentiate. So first three features are same, but the last three can help you answer these questions. Now remember that the drug of choice for PKDL is miltefosine, while here this is LL type of leprosy, that is multibacillary type of leprosy. So here treatment is MB, MDT, multibacillary multi-drug therapy. Now remember, this miltefosine is drug of choice for PKDL, but if they ask you the drug of choice for visceral leishmaniasis, that is Kala Azar, this is PKDL post Kala Azar. If they ask you for Kala Azar, then answer will be liposomal amphotericin B. Okay, so as I told you, if the vitiligo depigmented lesions where there is absence of melanocyte is localized to one small area, we call it focal. Then acrofacial, you will find these lesions over face, so facial and acral part, like you can see over hand or feet. Then segmental type, if the lesions are unilateral along a particular nerve segment or dermatome. So if they are unilateral along a particular nerve segment, then segmental. Sometimes these lesions, not only the skin but the hair follicles also get depigmented. This is known as leukotrichia, and this is one of the poor prognostic marker. There is sometimes this term is used, trichrome vitiligo. Trichrome, this generally occurs when we start treatment. So what happens, the lesions were initially depigmented, so this is a depigmented lesion, but when we started treatment, what happened, they become hypopigmented, so there is some color which is being gained, so this becomes hypopigmented, and there is this normal skin. So you can see three colors are seen together: normal, depigmented, hypopigmented. This is known as trichrome vitiligo. Then there are UV chambers which are available. If the patient is having lesions over almost whole body, then you can ask the patient to cover eyes, because these are UV radiation, they might lead to cataract. So cover the eyes and so wear glasses and go into the UV chamber and stand there. Okay, this is generally done for when there is a lot of skin involvement. But when there is localized involvement, like in this patient, there might be acrofacial type, only hand and feet are being involved, so you can use these hand units and foot units. Okay, so they are available in hand and foot unit also. They are available in the form of chamber also. So these are UVA chamber, and you can keep it in your clinic or hospitals, and patient can come every alternate day and they can go ahead with phototherapy. If these are not available, you can simply ask the patient to show sunlight. Then pityriasis alba, I told you that in pityriasis alba, generally hypopigmented single lesion is present. So you can see this hypopigmented lesion which might be present. There might be multiple lesions also, but generally in a child over face, this hypopigmented lesion is present. And if you closely examine, take a hand lens and closely examine, you will find scaling over them. Okay, so these are scaly lesions. Okay. Then pybaldism, I have already discussed in the beginning. Again, I am going to tell you that this is a genetic condition where there is absence of melanocytes, and this is generally localized to one area, like you can see frontal scalp or forehead. There is associated white forelock, and elsewhere if it is present, look for these areas of normal pigmentation in between. Okay, so white forelocks are associated with pybaldism. Then albinism also we have discussed. I told you that there is a gene mutation in the tyrosinase gene, due to which there is defective melanogenesis, and due to this genesis, patient develop generalized depigmentation of the skin. There is loss of hair color, and in the eyes also you might find depigmented lesions, or patient might present with photophobia or nystagmus. So if these findings are present, then we should label it as albinism. Then this is one very important test to differentiate various depigmented conditions from vascular conditions. Like I told you, you can differentiate nevus acromicus from nevus anemicus. We have already discussed in detail in the introduction part in the beginning. So there I told you that nevus acromicus and nevus anemicus can be differentiated with diascopy. When we do diascopy, you will find it can be differentiated in cases of acromicus, while the lesion cannot be differentiated from the surrounding skin in cases of anemicus. If you have missed that and if you do not recall, you can go back in the introduction part and there you can read it, where we have discussed melanocytes. Then this is heterochromia of the iris. Heterochromia of the iris means different color of the iris. You can see here. Okay. Now when this heterochromia of the iris is associated with broad nasal root and dystopia canthorum, that is the distance between inner canthus increases in comparison to the normal individual. So when this feature is associated with white forelocks and sensory neural hearing loss, then that is known as Waardenburg syndrome. And once this question was also asked, so remember, you might read this in ENT also, because there is sensory neural hearing loss. So first is heterochromia of the iris, second is sensory neural hearing loss, third dystopia canthorum. Dystopia canthorum means the distance between the inner canthus increases and there is broad nasal root with white forelocks. Now white forelocks we have seen in pybaldism also. So pybaldism is not the only condition where white forelocks are associated. If white forelocks are associated with these features, that is broad nasal root, heterochromia of the iris, sensory neural hearing loss and dystopia canthorum, then it is suggestive of Waardenburg syndrome. Okay, so remember that these are the features which are associated. So whenever, if in the question white fold locks is mentioned, then look for other features. If the features are like localized depigmentation, normal areas of the skin are also present in between, then mark piebaldism. And if these features are mentioned like sensorineural hearing loss, heterochromia of the iris, broad nasal root, or dystopia canthorum, distance between the inner canthus has increased, then mark Waardenburg syndrome. Okay, so these were various hypo and hyperpigmentary disorders.